and carry this back like this. So this is the C7 left side going into extension. Now let's take the C7 right side going into extension so you can see what I'm doing. So I come in here, my hand places itself as if it is the C7, and I can now lift her a little bit into extension like that, stop this one rotating in the direction of right by putting it on the left side of the spinous processes, and so I can encourage the right side to go backwards, left side to come forwards when I'm trying to bring about some degree of rotation at the C7 T1. So that's one technique that's very, very satisfactory. Here's another technique. Can you just lay on your stomach, please? Now, what I'm going to do now is to ask Sandy to just turn her head a little to the left, because that's the way I'm trying to rotate. And I'm going to place my hand over the facet joint of C7. My other hand is going to go under the shoulder and rotate it to the right, which will resist left rotation of C7. So now I just go through here and just push downwards, 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 like that, to encourage the forward and upward gliding of the right C7 facet joint, like that. These two techniques are really quite excellent techniques. And you've got a lot of stability here, and it's really making sure that that very difficult area to do, C7, T1, can be satisfactorily handled. Now, both of these are mobilizing techniques, and I'm not suggesting that we should do these as manipulation at all. These are mobilizing techniques.
Do you want to emphasize the flexion of C7 though? It seems like you're stuck in flexion and you want to get to.
Yeah, that's a reasonable point, so that you may be that this one here I'm just taking it forward, but we've got the one here where we can take it backwards into extension. Come up onto your elbows. So I can come into this and go back up like this. So we can mobilize it in both directions. I quite like this particular technique here, notwithstanding what was a very good observation from Clay here, but I quite like this technique of just gently pushing around to get some motion into, mobilize into flexion. I found it to be quite useful in terms of improving range of just turning to the side. Yeah. All right, let us just try those techniques. So just remember what we did there. Just lay on your back. We did the one of just holding down and just sort of pulling up like this. Not anything very specific with this one. Almost like a translatoric massage in actual fact. Then we went into perhaps I like listening to the sound of my own voice. I suppose there is that. But I think one of the reasons I teach is certainly that it improves my own skill level. It's rather like having a kind of a coach, although it's an internal coach. And when you find out that Ivan Lendl and Boris Becker and all these people at that level of playing tennis still go out on the courts with their coaches who tell them that's not doing quite right and you're not sort of holding that and all this kind of stuff. And it's so easy, isn't it, to get into kind of scruffy habits. And so I find with teaching, one of the things is that you are so much better for a while after you've done a course and before you've done the course, because you're thinking, oh, I'll do this and I'll do that. The only downside of that is I sometimes forget patients. My receptionist comes and says, have you forgotten that patient in number 5? They've been laying there for about an hour and a half. So I have to go in and say, I have a very difficult patient just before you. Because you're sort of thinking about things and you're thinking it through in your head and you sometimes get lost. So that's one of the reasons I teach. But the other reason that I teach is from what I sort of see here, which is a sort of an enthusiasm which you tend to, as you get older, you tend to lose a little bit. you know, and it revitalizes myself to sort of see the enthusiasm in this group, both for the way that you're acquiring information, for the way that you're handling people, for the way that you sort of interact with me, and that's very nice. And that's one of the real reasons that I do teach. It really charges up my batteries. So I shall go back, and for a while I shall be quite enthusiastic again. Patients won't irritate me, or it'll go all over my head. And so that's what you're giving me, and I hope that you know, I've been able to give you what you came for as well. All right, yes?
Do you have any recommendations on journals, international journals that you refer to?
Yeah. I took Scott Haldeman's advice, you know, the PhD, MD chiropractor, who's a neurologist and who's been the great white hope of chiropractors, and is always put forward as being the kind of information source for chiropractic. And there's no question that this man has got a fantastic pedigree of science. And so when he speaks on behalf of the chiropractors, they all bask in that reflected glory of Scott Haldeman. And Haldeman did write an article, and it was published in 3 journals actually, on the value of not reading single journals. In other words, more positively, the value of reading multiple journals. Now the question is, what exists out there? And what he suggested was that you look at a magazine like The Spine, which is kind of mixed. I mean, a lot of the time it's totally irrelevant. It's perhaps surgical procedures with various kind of fixations for scoliosis and all this stuff, and fixed rotatory displacements of the atlas using somebody's particular screws and plates and all this business. However, a lot of the information that's coming out in terms of the various ligaments and so on is being published in the Spine magazine. So that's really where it's at, I suppose. The other journals that Scott Haldeman suggested that people read were the Journal of Manipulative and Physiological Therapeutics, which is produced, it's a chiropractic magazine, it's produced by Williams and Wilkins, and I subscribed to that for 2 or 3 years, and I'm continuing my subscription. I find it quite a good magazine, or quite a good journal. Yes, it's the JMPT, the Journal of Manipulative and Physiological Therapeutics. And that's the chiropractic magazine. Its editor, Keating, is very good. I kind of like the way he looks at things. He's always talking about how valid is the stuff that we do. And it's a good magazine, I find, and I hope that that we'll be able to sort of emulate that. Then Haldeman suggested that we should get another journal, you needn't write this one down, which was the Journal of Manual Medicine, which was really an excellent journal. I subscribed to it for a year, and after 3/4 of a year, it went belly up. And so it's not in existence anymore. That was a very good journal, I found. It was the official journal of the Federation of International Manual Medicine, but they could not get the people in medicine, when there's like 9,000 or something over worldwide of doctors who are in manual medicine. They needed 500 subscriptions, they couldn't get 500 subscriptions. Pretty tragic. And yet it was a good magazine. People like Lewitt and Dvorak and Yanda. Dvorak actually was the editor-in-chief of this journal, so it was an excellent journal. He also suggested that you should get another journal which was called Chiropractic Technique, which was also published by Williams and Wilkins. I took the subscription for a year, and I haven't renewed my subscription. I found that it was really not what I would want. And I found that the techniques were actually somewhat less sophisticated than I would have liked. So I've not renewed my subscription. Then, of course, there's the new journal out that is being produced by Stan Paris, which I think will be hopefully an excellent journal. This is what Dan Lee got an article in the first edition, on which everybody received a free copy. And I think we should support that. I hope that it will become the same kind of a journal as the JMPT, and it'll be our voice all over the world, and I'm hoping that we should be able to establish. You see, I think when we're looking at like the problems that you have in Washington, if we have got a journal that is refereed and it is sort of recognized over the long haul, because you look back at the JMPT and that's pretty pathetic to start with. I mean, it takes a while for this to go, but I think if we look over the world as a whole, we've got to have some voice for manual therapy in the world. We've got to have books that show our techniques, not that we've kind of modified somebody else's technique. That's perhaps for you guys to do, not perhaps I should be there sort of sanding my grandfather clock that has been building for 10 years. That's still, I haven't done the hood yet, I'm still got the base there, and I was looking at it the other day thinking to myself, got to get on with that before I die. I don't know whether I'll do that, okay? But no, whether I'll get it done before I die, that's right. Okay, so there are those journals out there. Now, there are a number of others which I'm not particularly familiar with, you know, like the Journal of Spinal Diseases and all this. I think it'd be nice if you could get access to these, but not necessarily subscribe to them. But certainly the JMPT is good, and I hope ours is going to be good, and the spine is kind of like the basic standard thing. For all its downside, it's still probably half of the time very relevant to us, and it's where everything is at in terms of what we should be looking at. And so I would think that although it's very expensive, it's still, you know, where it should be, and I think we should get that.
Can I
Yes,
ask
sir.
a stupid question?
No question stupid, Chris.
Well, this is probably a Dutch question, David will ask. Suppose with a group like this or with the Institute, we will subscribe to 6 magazines.
Yeah.
And can we make photocopies out of it and distribute under our members or not?
I would rather not answer it. Yeah.
Okay, so you always...
I think the thing about this is that, you know, the thing is that generally you don't have to do photocopies. You can always write to the author and get a copy from them. I sort of have no problems in photocopying stuff that's out of print and you can't get it and it's not, but I don't think you should photocopy stuff that is being supported by subscribers and, you know, and then it goes broke. I think that's a shame.
Okay.
So,
But my question was, then we could subscribe to, let's say, 10 magazines and support 10 magazines,
yeah.
and then pick the good stuff out of it and distribute.
Well, you know, I think that's fine. And what each individual person does, like I do with my journals, I mean, I sometimes find a copy and I photocopy it and give a couple to my colleagues because I know that they look at the one that I've got in the sort of little institute, that sort of thing. But and I think that if you've got them and you pass them around and people say, I'd like this one, I think that's sort of photocopying for personal use. And I think still it's illegal, but everybody does it.
You can photocopy part of an article, but
Yeah.
you can't photocopy the entire
article.
for purposes of distribution.
Yeah. So I think, you know, we should stay with this. But if you subscribe to a number between you and these are passed around, I've tried that though, and it doesn't seem to get distributed all that well after a while. You know, you want your own, and you want it right now when it's arriving. For whatever. And then I've got them all sitting there by the side of my bed waiting to be read. Yeah. Okay, were there any other questions there? All right. What I'd like to do today, there are one or two things in the lumbar spine that we haven't done, and we broke off yesterday because I just didn't want you to get too sore. Have we got any soreness in any of the groups? Anne was telling me that her soreness in her back was not created by her being manipulated, but her manipulating. She stood in the wrong place. And this is why it's very good to have Anne here, because Chris is my build, and so we can kind of move with sort of brute strength. Anne needs a little bit more skill to do all this, rather than sort of just hammering through. And so it's very nice for the women here to sort of speak to a woman and say, how do you get over this? And it's very hard for us to put ourselves in sort of somebody that's a bit weaker shoes because you've never had to do it or to bother about that. And so this is what's so excellent about having an associate in a teaching situation that's female, that can show those different varieties of getting complete efficiency in a slightly different way. There's no doubt that women have to be a little more skillful and men have to be a little less rough. That's the sort of I'm going to say less skillful, more skillful. I don't mean that they're not skillful to start with, but more skillful than possibly the males who can get through with a little bit more strength. You just have to use much more of your exact body mechanics, because these techniques, as you realize, when I come and do some of these, we talk about, you know, they're not gentle techniques. They're precise and they're quick, but they are still forceful. But that force is over such a small distance, the way that we do it, that it should be safe. I know in one of the articles in the last of the journals of manual medicine that came out, it was kind of extolling how important it is to do high velocity, high amplitude movements to get any effect. This is in the cervical spine. And you think to yourself, when you look at all these things, and there's the chiropractors that have produced accidents, and there's the physiotherapists that's produced accidents, and there's this kind of indefinite group, and doctors are never mentioned, medical doctors, and yet they're sort of extolling the business of doing high velocity in some cases, and I don't mean all of them. People like Dvorak and people like Gutman, it's very much a precise procedure. But it's got to be fairly precise, but on the whole, you are still imparting force to that joint. But it's the, can we produce blocks so we don't overdo it, as we did yesterday with the lumbar spine? If I'm rotating, it's a big difference from if I'm rotating into me than if I've got a big space there and I'm pulling down here, and if anything goes wrong, then this over-talking is going to take place. And we've tried to get right away from that so that we don't cause any problems. Perhaps I think with Bill, he'll have to say, no, my body's in the way there, so I do not. I can give the impulse, but I do not exceed the physiological limit because my body's there stopping that, and everybody else should do it. How's that, Your Honor? Okay, so yesterday we looked at the lumbar spine and we stopped. And we sort of carried on with the cervicothoracic junction. And what I'd like to do, rather than sort of make another break and go back to the lumbar spine, is to sort of complete the cervicothoracic junction. Then we'll go to the lumbar spine. Then we'll come up back to the thoracic spine. So it'll give us a little bit of a break from doing things in the thoracic spine, albeit very high, before we get into the thoracic spine proper. So here's what I think we should sort of consider. I gave you that little homily yesterday about the importance of this area. And there's absolutely no question that this is a key area. Lewitt thinks it's the third key area in the body. He feels that the craniovertebral is the first area where dysfunction makes a difference all over the body. And that's probably from a neurophysiological point of view, because of the reflexes and everything that are affected by alterations of the craniovertebral input. He feels that the next important area is the lumbosacral area, because this is the sort of base area of the body. So you could look at the two great schools of thought, one who feel that we should be going on neurophysiological principles, and the other group that start from below upwards that look at the sort of biomechanical base, and if the base is inadequate, then all sorts of adjustments take place up there. And so he goes along with that too. And then he says we come back to the cervicothoracic junction, and that is the third key area. And we're always dealing with junction zones, aren't we? These are the difficult ones often to get at. In this case, because of not so much getting at them, but because of consequences of dysfunction and, of course, of the vertebral artery and those interspinous ligaments. We can come down to this area, and we've got the difficulty just in getting at it, because the lever system of the rest of the neck has to be taken into consideration. We've got the whole problems of the upper ribs. We've got the problems of the thoracic outlet. So this is kind of difficult area to get at. Then we go to the lumbosacral junction. That's difficult from the amount of stability that exists there very often, and just having sufficient strength with the stiff ones to move them efficiently without doing any dangerous or perhaps not dangerous, but movements that might cause some exacerbation. So we've got that to consider. Then we come up to the thoracolumbar junction, which is the other big junction zone. Once again, we've got difficulty there in getting at it, because the lever here is long and the lever there is long, and we've got to sort of try and accommodate those levers. And very often we know that we'll probably get stiffness or hypermobility in the region of a junction zone, because very often the movement from one area is changing. I drew a very good analogy when I was on a course in the United States. Nobody knew what I was talking about. Couldn't believe this. I talked about an electric kettle. You all know what an electric kettle is, don't you? What do you mean electric kettle? You mean a crock pot? So no. I'm talking about an electric kettle. Well, like that thing that you've got there that's sort of going with a flex. And where does the flex always go? It's where the flex goes into the, or where the mains cord goes into the kettle, where we've got no movement here, we've got this thing here that can move, and just here we've got all that movement. And this is where we get hypermobility, where there's a stiff area going into a very mobile area. So when we look at the cervical spine, we've got this incredibly stiff area of the cervicothoracic junction, and we start getting problems at like C5 and C6 and C6 and C7. And then we're into the stiff area. And this is what really bothers me, sometimes about some of the techniques, and this is no criticism of any school, because I don't think we're in that business. I mean, when I look at the Mackenzie protocol, that's been so useful for a lot of the lumbar spine, but now it's getting put into a kind of like a pervasive technique for treating everything. You kind of wonder if the same amount of work has been done in this area as was done in the lower area. And when we've got patients who are kind of hanging over tables and pushing back in this position, which of course is exactly the opposite movement to an increase of lordosis, and nobody is addressing mobility of the cervicothoracic junction, what happens to those lower joints? They've got to become hypermobile. You don't usually, by doing all these things, mobilize a stiff area. You increase the mobility of the normal areas. That's what usually happens in the body. And this is a tough area to work on. And the techniques of mobilization are so important in this area, and that's why we need to sort of think about them. So what I'd like to just start with today is this. We should perhaps think just very briefly, because you've done all this before. You've done it, I think, some of you with me, and you've done it in other courses with Anne and with Earl and so on. So we don't need to spend a lot of time sort of just considering some of the basic examination principles. You've done all that sort of stuff. But just to get us moving, one of the problems when we think about the cervicothoracic junction is the tendency for higher areas to refer pain here. So we need to have one or two little exclusive tests we can use, or perhaps not exclusive, excluding tests, I guess, that we could use to make sure that it's not the cervical spine. What are you doing with that? And perhaps we could have little discussions within our groups or within the whole group to see how we're doing that. Then I think we should just consider for a moment or two one or two quite useful soft tissue techniques which we've tried to do, leading on to perhaps translatoric techniques which are very useful in this area, combining these two, and then perhaps just to get us into the way of working, one or two very essential mobilizing procedures. And then we can do the manipulation, which I use fairly frequently. I find them quite good. When we discuss the cervicothoracic junction, we should probably think in terms of three areas, possibly. We should think of C7, T1, and any specific techniques we can do around there. And as Clay said yesterday, it's a very important thing to sort of consider that C7 is usually set forward. And we had a look at two techniques which mobilized it forward. We also looked at a technique that mobilized it backwards. And I'd like to show you another technique which we can mobilize it backwards also, because it's an important thing. Next thing that we should look at is the T1 to probably 2 area. and involve in that both the vertebral movement and the first and second ribs. We probably won't do that just now. We'll leave that till we do all the ribs together. So you look at the difference between the way that we can move ribs. But then again, you've done some techniques on there as well. So this will be kind of a nice review for you. And it'll also be interesting to me to see how my other colleagues do these things. And then we'll do from T down to about 4. So we're really considering the cervicothoracic junction T1 to 4 with C7 distinctly affected, particularly by this area. And if we look for hypermobility, we'd probably find it at 4, 5, 5, 6, going along with stiffness in this area. So let's just start with a very little assessment, both in terms of trying to do some excluding tests and also some intervertebral joint motions in this particular area, if you would. You remember that in my discussion with you yesterday, we also included a whole pile of stuff, particularly soft tissue problems, which can cause tightness and weakness. And this was Yander's upper crossed syndrome, which we looked at yesterday. And it's interesting looking at different people who lecture. Clay was telling me about Shirley Sarman, who's of course done some excellent work in terms of muscle, and she kind of feels that the safer way to get a muscle to stretch is to work its antagonists in a kind of a contract-relax technique, and I think that's true. The trouble is that we've got this conflicting evidence of Yander, who says that that's largely futile. Particularly if we look at the difference between these huge great muscles like the pectoralis major and the pitiful muscles such as the interscapular group. It may not be possible ever for those interscapular muscles to produce enough retraction of the shoulders to pull out the pectoralis major. We've probably got to do considerable amount of stretching on that muscle for the clavicular fibers, the sternal fibers and the abdominal fibers, and in this, and give patients distinct exercises of stretching to do. Because as I said yesterday, when Yander looked at the abdominals and the back extensors, the people were working on the abdominals very much and very conscientiously, but they weren't producing anything because we've got all this inappropriate recruitment. So when he did some stretching on the back extensors, not only did they become quiescent on a sit-up, but they also allowed the abdominals, without any work at all, to increase their strength. And so, you know, we've got kind of conflicting evidence, and I think what we have to do is to say to ourselves, let's try this a little, let's try that a little, and then we put together and synthesis, you know, and Suzanne's synthesis, because you've had your experience from all the things you've done, and this is the group of things that you're doing. And in an institute like this is what these seminars and things are about, for us all to share our ideas so that we come up with some consensus, which at least for this year is going to be the way we're kind of all experimenting a little bit. And next year we all find that some of that wasn't very good, some of it was extremely good, so that sort of becomes a bit more permanent. I reckon that's where we should be going with all this stuff. There's no hard and fast answers for any of this, especially when we're dealing with the neuromuscular skeletal system. This is a system that is going to ebb and flow with all kinds of influences going in, and I think we should be aware of that.